Good morning, everybody. My name is Kirsten Smith, and I am at Johns Hopkins University. This one?
On the right.
The one right? Which one? Okay, so I just want to make sure the clicker works. So I am going to be talking about people who, not in controlled studies, but just in America who use Kratom. I've been studying this since 2017, and there's actually a lot of parallels with what we're seeing in the United States with actually what we see in indigenous use, including what Dr. Singh presented in Malaysia. So in the United States, Kratom has actually been used for at least 20 years that we can have documented. In fact, Dr. Boyer had one of the first verified reports of use in the United States. And what we know is now, Kratom is not just the botanical, right? So in America, we have a diverse set of products that are derived from this botanical, but there's actually a lot of consistency across these products. And we see that consumers are typically titrating Kratom products to suit their needs, right? This is from a recent study, and I'm going to be showing several slides related to the study funded by the National Institute on Drug Abuse, in which we assessed Kratom use among a national sample of people who have been using for a long time, most of them over a year. And what we see is that many people in the sample are using in a fairly regimented way. Some have a little bit more variability than others, but everyone kind of falls into their own kind of groupings of different use patterns. But what we don't see is binge-like use or heavy weekend use, things like that, and that the amount that people are taking are consistent. We have, again, really thousands and thousands of use events assessed with ecological momentary assessment, and we see a very nice, consistent, and orderly pattern of use. Also, with respect to the products that people are taking, this is not published, it's under review, but the Kratom products that people were taking in our study were analyzed in collaboration with the University of Florida, including Dr. McCurdy here. And what we see is that the alkaloid composition, so the chemical composition, was actually fairly consistent across products. It matched what we would expect for the species, the species of botanical. There was not any drug adulteration that was found, and that on average, the mitragynine or mitragynine, we all say it differently. We cannot agree on how to say it. Mitragynine, which is the major alkaloid, the most prominent alkaloid or chemical in Kratom, the average intake was about 31 milligrams per use, and the mean daily intake was around 134 milligrams daily. 7-hydroxymitragynine, which is something we've not talked a lot about, it was really not found at all. It was trace amounts across products. And so what we're learning about this, again, this is a very complex botanical, so we can't unpack all of it, but this important constituent is actually not really found in Kratom leaf or products that we've tested so far. So a lot of use is in keeping kind of like how we drink coffee at different times of day. A lot of the use we see is very similar to that. Not a lot of intoxication. In fact, the DUI cases, we don't even have a lot of information about if intoxication was found. In my studies, we have not found intoxication. So we're not seeing people seeking out highs, but rather a lot of these immediate drivers of use, again, assessed momentarily, pain relief, improving mood, energy, focus, alertness. And then we also know that long-term people are using as a harm reduction tool, very similar to what Dr. Shan was discussing in Malaysia. We've seen very similar things in the United States with not only opioids, but also alcohol. Not so much methamphetamine, but alcohol has been a bigger one. We also see when we look at things like addiction or physical dependence, when we look at the specific criteria for meeting a substance use disorder for Kratom, what we now call Kratom use disorder, most of the symptoms you can see here on the right are basically physical dependence, right? So tolerance and or using to avoid withdrawal. And that's what we know can happen with daily use of many, many other substances as well. Similar to what Dr. Singh had discussed, the withdrawal symptoms are typically mild to moderate. This has been both in Southeast Asia and in the United States when people are reporting this, but it's only been very recently that we've had any empirical data. So I have one clinical trial at Hopkins right now in which people who've been using Kratom for a very long time come in, and we do a lot of different assessments, but at the end, we tell them to stop taking kratom. And we are now assessing kratom withdrawal in an inpatient hospital setting, and it is in keeping with the self-report historically. So to conclude, after decades of use in the United States, kratom, this is, I think, a very important point. It refers to a very diverse set of products, right? So we have the botanical that's growing in Malaysia, Indonesia, and then we have the botanical in different kinds of products. So we always have to talk about what kind of kratom people are taking, but it is all this, it is botanical derived, and it's a set of supplement products that are legally sold, which I don't think we've really touched on much, but these are legally sold and consumed in a way that's pretty normative, right? So we need to do more research, but from what we can tell now, both the composition of these products and the way that people use them is converged into a fairly normative set of use patterns in chemical composition. And so that is what I will conclude with.